Welcome to the lecture on mental disorder, and after this lecture, we will be able to learn the following objectives. Explain the mental disorder, define the eating disorder, describe the mental disorder treatment. Let us begin with what mental disorder is. Mental disorder are common in medical practice and may present either as a primary disorder or as a comorbid state. The occurrence of mental or substance use disorders in the United States is 18.5%, resulting in an annual cost of $148 billion, only slightly less than the cost of cardiovascular diseases. Only 15% of these individuals are currently receiving treatment. A mental disorder is a health condition characterized by significant dysfunction in an individual's cognitions, emotions, or behaviors that reflects a disturbance in the psychological, biological, or developmental processes underlying mental functioning. Some disorders may not be diagnosable until they have caused clinically significant distress or impairment of performance. The current system of classification is multi-racial and includes the presence or absence of a major mental disorder, any underlying personality disorder, general medical condition, psychological and environmental evils, and overall rating of general psychological functioning. Changes in healthcare delivery underscore the need for primary care physician to assume responsibility for the initial diagnosis and treatment of the most common mental disorders. Prompt diagnosis is essential to make sure that patients have access to suitable medical services and to maximize the clinical outcome. Validated patient-based questionnaires have been developed that systematically probe for signs and symptoms associated with the most prevalent psychiatric diagnoses and guide the clinicians into targeted assessment. PRIME-MD and a self-report form, the PHQ, and the symptom-driven diagnosis system for primary care SDDS-PC are inventories that require only 10 minutes to complete and link patient responses to the formal diagnostic criteria of anxiety, mood, somatoform, and eating disorder, and to alcohol abuse or dependence. A physician who refers patient to a psychiatrist should not only, when doing so is appropriate, but also how to refer, since societal misconceptions and the stigma of mental disorder impede the process. Primary care physicians should base referrals to a psychiatrist on the presence of signs and symptoms of a mental disorder and not simply on the absence of a physical explanation for a patient's complaint. The physician should discuss with the patient the reason for requesting the referral or consultation and provide reassurance that he or she will continue to provide medical care and work collaboratively with the mental health professionals. A mental disorder is a mental health condition assessed as abnormal or maladaptive and involving significant distress or disability. Mental disorder could be of various types. Some of the major mental disorders are phobias, mood disorders, cognitive disorders, personality disorders, schizophrenia, and substance-related disorders like alcohol dependence. Behavioral health care professionals call disorders or diseases that have prominent emotional, behavioral, and psychological symptoms mental disorders. These include substance use disorder and disorders associated with physical changes or disorders, many of which directly affect the brain. For most of these disorders, however, physical causes have not been demonstrated or are purely understood, even though biological treatment, example drugs, may be effective in treating them. They may be distinguished from and classified separately from the personality disorders, or the term may be used in such a way as to include personality disorders. Experts say we all have the potential for suffering from mental health problems. No matter how old we are, whether we are male or female, rich or poor, or ethnic group we belong to, in the UK, over 250,000 people are admitted into psychiatric hospitals each year, and more than 4,000 people kill themselves. They come from all walks of life. The most common forms of mental disorders are anxiety disorders. Anxiety disorders are exaggeration of our normal and adaptive reactions to fearful or stressful events. The most common group of mental disorders, the sufferer has a severe fear or anxiety which is linked to certain objects or situation. Most people with an anxiety disorder will try to avoid exposure to whatever triggers their anxiety. Examples of anxiety disorder include panic disorder. The person experiences sudden paralyzing terror of imminent disaster. Phobias. These may include simple phobias, disproportionate fear of object, social phobias, fear of being subject to the judgment of others, and agoraphobia, dread of situations where getting away or breaking free may be difficult. Obsessive compulsive disorder (OCD). The person has obsessions and compulsions, in other words, constant stressful thoughts, obsessions, and a powerful urge to perform repetitive acts such as hand washing compulsion. PSTD, post-traumatic stress disorder. This can occur after somebody has been through a traumatic event, something horrible and scary that the person sees or that happens to them. Mood disorders. These are also known as affective disorders or depressive disorders. Patients with these disorders share disturbances or mood changes, generally involving either mania or depression. Experts say that approximately 80% of patients with depressive disorder improve significantly with treatment. Schizophrenia disorders. Whether or not schizophrenia is a single disorder or a group or related disorders has yet to be fully determined. It is a highly complex disorder with some generalization which exists in virtually all patient diagnoses with schizophrenia disorders. Most sufferers experience onset of schizophrenia between 15 and 25 years of age. Mental disorders usually are caused by a grouping of genetic and biological factors, nature, and environmental factors, nurture. Substance use and other medical situations also can play a role in mental problems. Although it is difficult to separate the role of factors in an individual presentation of mental disorder, it is important to understand how these factors independently affect mental functioning so prevention and intervention can be implemented. Many mental disorders have a genetic part, meaning a tendency or vulnerability to a particular disorder can be passed down through family. According to 2000 Diagnostic and Statistical Manual of Mental Disorder DSM-4-TR, individuals with first-degree relative distress from schizophrenia are at 10 times greater risk for getting the disorder themselves compared to the general population. Major depressive episodes are between 1.5 and 3 times more common in individuals with first-degree relatives who also suffer from major depression. In addition, alcohol dependence, anxiety disorders, and attention deficit hyperactivity disorder (ADHD) have been found at increased incidence among those with first-degree biological family members with major depression. Bipolar disorder have a strong genetic factor. Increased incidence of either bipolar 1 or bipolar 2 disorders have been found to be between 4 and 24% in those with a first-degree biological relative with the disorder. Environmental conditions also play a large role in the development of or resilience to mental disorder. Many parents struggle to provide consistent, patient, and nurturing environment for their children. Consistency, neglect, and abuse on the part of the parent, lack of appropriate food, vitamins, or doctor visit, for example, can affect the child's development as well as affect his ability to construct a healthy model of interpersonal relationship and social behavior. Sometimes, symptoms of mental disorder arise due to a physical change or medical condition. Traumatic brain injury can result in personality changes, although these changes are not always negative. Other medical conditions such as diabetics also can affect mental health. If uncontrolled, blood sugar fluctuation in diabetics can cause significant fluctuation in mood, temper, impulse control, and cognitive acuity. Substance use and abuse is often embodied with mental disorder. It is often difficult to determine if substance use triggers underlying vulnerabilities, For mental disorder, or if individuals are self-medicating a pre-existing mental disorder, but the substances themselves can cause symptoms of mental disorder. An eating disorder is a disorder that causes serious disturbances to your everyday diet, such as eating extremely small amounts of food or severely overeating. A person with an eating disorder may have started out just eating smaller or larger amounts of food, but at some point the urge to eat less or more spiraled out of control. Severe distress or concern about body weight or shape may also characterize an eating disorder. Eating disorder frequently appear during the teen years or young adulthood, but may also develop during childhood or later in life. Common eating disorder include anorexia nervosa, bulimia nervosa, and binge eating disorder. It is unknown how many adults and children suffer with other serious, significant eating disorder, including one's category of eating disorder called eating disorder not otherwise specified. EDNOS. EDNOS includes eating disorder that do not meet the criteria for anorexia or bulimia nervosa. Binge eating disorder is a type of eating disorder called EDNOS.3. EDNOS is the most common diagnosis among people who seek treatment. Eating disorder are real, treatable medical disorder. They frequently coexist with other disorders such as depression, substance abuse, or anxiety disorder. People with anorexia nervosa are 18 times more likely to die early compared with people of similar age in the general population. Eating disorders are so common in America that 1 or 2 out of every 100 students will struggle with one. Each year, thousands of teens develop eating disorder or problems with weight eating or body image. People with anorexia have a real fear of weight gain and a distorted view of their body size and shape. As a result, they cannot maintain a normal body weight. Many teens with anorexia restrict their food intake by dieting, fasting, or excessive exercise. They hardly eat at all, and the small amount of food they do eat becomes an obsession. Bulimia is similar to anorexia. With bulimia, someone might binge eat to excess, and then try to compensate in extreme ways such as forced vomiting or excessive exercise to prevent weight gain. Over time, these steps can be dangerous both physically and emotionally. They can also lead to compulsive behaviors, ones that are hard to stop. This eating disorder is similar to anorexia and bulimia because a person binges regularly on food more than 3 times a week. But unlike the other eating disorders, a person with binge eating disorder does not try to compensate by purging the food. Anorexia, bulimia, and binge eating disorder all involve unhealthy eating patterns that begin gradually and build to the point where a person feels unable to control them. Sometimes, a person with anorexia or bulimia starts out just trying to lose some weight or hoping to get in shape. But the urge to eat less or to purge or over-exercise gets addictive and becomes too hard to stop. Teens with anorexia or bulimia often feel intense fear of being fat or think that they are fat when they are not. Those with anorexia may weight food before eating it or compulsively count the calories of everything. People to whom this seems normal or cool, or who wish that others would have leave them alone so they can just diet and be thin, might have a serious problem. Like females who have eating disorders, males also have a distorted sense of body image. For some, the symptoms are similar to those seen in females. Others may have muscle dysmorphia, a type of disorder that is characterized by an extreme concern with becoming more muscular. Unlike girls with eating disorder who mostly want to lose weight, some boys with muscle dysmorphia see themselves as smaller than they really are and want to gain weight or bulk up. Eating disorder are complex conditions that arise from a combination of long-standing behavioral, biological, emotional, psychological, interpersonal and societal factors. Scientists and researchers are still learning about the underlying causes of these emotionally and physically damaging conditions. We do know, however, about some of the general issues that can contribute to the development of eating disorder. While eating disorder may begin with preoccupation with food and weight, they are most often about much more than food. People with eating disorder often use food and the control of food in an attempt to compensate for feelings and emotions that may otherwise seem overwhelming. For some, dieting, binging and purging may begin as a way to cope with painful emotion and to feel in control of one's life, but ultimately these behaviors will damage a person's physical and emotional health, self-esteem and sense of competence and control. There is various childhood personality traits associated with the development of eating disorder. During adolescence, these traits may become intensified due to a variety of physiological and cultural influences such as the hormonal changes associated with puberty, stress related to the approaching demands of maturity, and socio-cultural influences and perceived expectations, especially in areas that concern body image. Many personality traits have a genetic component and are highly heritable. Eating disorder often run in families. Risk of developing an eating disorder is 50 to 80% determined by genetics. Women with a mother or sister who has or had anorexia, nausea are 12 times more likely than others to develop it themselves. They are 4 times more likely to develop bulimia. One of the many downfalls of eating disorder in young people is that adolescents often think they are invincible. This is partially due to the very real physiological fact that a teenager brain is not fully developed yet. In particular, the part of the brain that links action with consequences is still gathering information to support the fact that there are consequences. Starvation. Starvation can have very serious effects on all major body systems and organs. The basic metabolic response to starvation is to conserve body tissues and energy. Dehydration. The healthy functioning of cells and tissues is dependent upon a certain level of water content in the body. Also, salt and other minerals need to be kept within a narrow range. In a person who has become dehydrated, it is possible they are suffering from depletion in salt as well as water. Long-term dehydration can ultimately lead to kidney failure. Muscle and cartilage. Over-exercise can put a huge strain on muscle and cartilage, particularly if the exercise is concentrated on one area for long periods of time. Bones. Osteoporosis is a loss of protein mattress tissue from bones, leaving them brittle and susceptible to fracture. Although it is a natural part of the aging process, the changes of developing osteoporosis later in life are significantly increased for anorexia due to hormone changes. Bones may also stop growing, which causes stunted growth in younger anorexics. The frequent purging that occurs with bulimia does serious damage to the body. Self-induced vomiting damages the digestive system. It can cause a peptic ulcer, which is an area of the stomach or duodenal lining which becomes eroded by stomach acid. These are known as peptic ulcers. Damages the esophagus, throat, since stomach acid irritates the esophagus, which can cause inflammation in raw areas, sometimes making swallowing painful. Of greater concern is a rupture of the esophagus because this can be fatal in some cases. Swollen salivary glands, stomach cramps and difficulty in swallowing. The severity of the eating disorder and any co-occurring disorders will determine the preliminary treatment level you or your loved one should pursue, though it is typical to begin with the outpatient level. Health professionals seen in the outpatient level of care can determine if a higher repeat of a care is needed and refer as necessary. The following are the common levels and types of eating disorder treatment in order of acuity. Outpatient treatment, seeing a therapist, counselor. Intensive outpatient treatment, IOP. Residential treatment. As part of eating disorder treatment are several types of therapy options that address a variety of aspects of the disease. These therapies can be part of a comprehensive treatment plan for recovery from an eating disorder. Some specific examples of these helpful therapies are art therapy, dance or movement therapy, dialectical behavioral therapy, family therapy, medical nutrition therapy. When considering which therapies to include as part of a treatment plan for an eating disorder, it is important to work with a health professional to determine what problems or underlying issues are priority in addressing the desires and strength of the individual participating in the treatment and the level of eating disorder treatment needed. Because of the multifaceted nature of eating disorder, they may often coexist with or be a state effect of other diseases disorder such as depression, trauma or anxiety disorders. It is common that eating disorder may not be the primary disease suffered, thus intensifying the need for treatment to address all co-occurring disorders. In addition to co-occurring disorders, there are a number of general topics and circumstances that affect or are affected by whether a person suffering with an eating disorder is male or female, teen or senior citizen, pregnant, an athlete, heavy dieter or weight loss surgery, recipient, a diabetic, medical complication associated with eating disorders. Though the road to recovery from and eating disorder is often a hard and challenging experience, there is hope in finding freedom from these disorders. Many men and women who are suffering with an eating disorder have unique needs and concerns. These can vary according to age, environmental and social factors, and other medical concerns. Mental disorder can be treated when someone first starts to develop symptoms of mental disorder. It is important to contact a doctor or a community mental health service for help. The correct treatment can help a person's condition to improve or in some cases recover completely. Treatment in the community rather than in a hospital is considered better for a person's mental health. Psychological treatment are often the most helpful for people affected by anxiety disorders or depression, while medications are mainly helpful for people more seriously affected by mental disorder. Sometimes the symptoms can be so confusing for the person that they do not realize they are ill. In this case, family or friends can visit the doctor to discuss what can be done. Now in the end, let us summarize what we have learned in this lecture. Medical disorders are common in medical practice and may present either as a primary disorder or as a comorbid state. Changes in healthcare delivery underscore the need for primary care physicians to assume responsibility for the initial diagnosis and treatment of the most common mental disorders. Mental disorder is a mental health condition assessed as abnormal or maladaptive and involving significant distress or disability. Mental disorder usually are caused by a grouping of genetic and biological factors, nature, and environmental factors, nurture. An eating disorder is a disorder that causes serious disturbances to your everyday diet, such as eating extremely small amounts of food or severely overreacting. Bulimia is similar to anorexia. With bulimia, someone might binge eat to excess, and then try to compensate in extreme ways, such as forced vomiting or excessive exercise to prevent weight gain.